Hello. Welcome to the first episode of the National Lipid Association's new podcast series, Industry Innovations. I'm Dr. Peter H. Jones. I'm a master of the National Lipid Association. I'm a former president of the NLA and a former chief science officer of the NLA. And I'm also a professor emeritus at Baylor College of Medicine. And I am thrilled to serve as your host, kicking off this series with a groundbreaking conversation with my friend and colleague, Dr. Guy Mintz. Guy is also a fellow of the National Lipid Association and of the American Society of Preventive Cardiology. He's the director of cardiovascular health and lipidology and the director of lipid apheresis at the Sandra Atlas Bass Heart Hospital and an associate professor of medicine at the Zucker School of Medicine. And he currently serves as the president of the Northeast Lipid Association. In this episode, Dr. Mintz will discuss insights on LODOCO, which is a FDA-approved drug from Agepha Pharma, and it's a low-dose colchicine. And we're going to review the clinical trial data demonstrating how this new therapy can reduce inflammation and reduce atherosclerotic cardiovascular disease. So this discussion is especially valuable for clinicians as it highlights a new avenue for risk reduction that could add to evidence-based and standard of care treatment approaches. Supported by Agepha Pharma, this episode of Industry Innovations is here to bring you the latest advancements in lipidology and beyond. So let me jump in now and let's get started with our dynamic discussion. So, Guy, based on what we're talking about today, which is targeting inflammation, if you can, why is inflammation an important target in atherosclerosis?
I think that's a great question because if you go back to our statin studies, we can say the best statin in the world may reduce cardiovascular events by 50%. So the question comes up, what else plays a role in plaque instability and the cause of our cardiovascular events? And inflammation, or what we refer to as residual risk, is a great target for us. And we can measure levels of inflammation by looking at high sensitivity C-reactive protein. We can even go back to the Physicians' Health Study, where they looked at the benefit of aspirin in reducing cardiovascular events in healthy physicians and showed that the group of, quote, healthy physicians that went on to have myocardial infarction, peripheral arterial disease, and stroke had high levels of inflammation. So I think as we move into an era of precision medicine or personalized medicine, not only do we have to look at cholesterol risk, but we have to look at inflammatory risk as well.
Yeah, I think that's important. I mean, we have to go back to our, cholesterol guidelines, and it's listed that, systemic inflammation is a very high risk state, and they list in the guidelines those systemic inflammation as being, rheumatoid arthritis, psoriatic arthritis, lupus, HIV positive, inflammatory bowel disease, as putting the patient at high risk. And those patients, obviously, because of systemic inflammation from those diseases, do tend to have higher incidences of cardiovascular disease events. And also, in the guidelines, as a risk-enhancing factor, it mentions that you can measure hsCRP to help you understand what that residual risk is. But also, there are many of the risk factors that we generally tick off as being important for atherosclerotic cardiovascular disease tend to probably have inflammation as their mechanism of increasing atherosclerotic risk. I mean, like aging, smoking, physical inactivity, even environmental pollution is listed as a risk-enhancing factor for inflammation, as well as diabetes, CKD. I think even though we may say, oh yeah, the patient has CKD or diabetes, obesity, that's why their risk is so high. It's probably background influences on inflammation that makes those high risk. Do you agree?
Oh, I totally agree. And, many of us are using the AHA-ACC 10-year risk calculator, which doesn't look at inflammation as a risk factor. And I think that's important. And the fact that HSCRP is listed as a biomarker to evaluate our patients becomes, very important. And just to, highlight that a little bit more, Paul Richter did a meta-analysis of looking at patients on statin therapy that were in the Reducer trial, the Prominent trial, the Strength trial, and he found that the group that had high sensitivity CRP of greater than 2, high LDL greater than 70 were the highest risk group. But the second highest risk group was the group that had high sensitivity CRP of greater than 2 and LDL less than 70. And that group was a higher risk for cardiovascular events in the group with the CRP of less than 2, but an LDL greater than 70. So this just was another, factor proving that HSCRP is an important risk factor of inflammation, contributing to cardiovascular events. And this was, as I said, the group on statin therapy.
Yeah.
So I think that it's important for us to keep in the back of our mind, Peter. And then if you go back to, I think it was 2017, the CANTOS trial, which was a trial of about 10,000 patients with atherosclerotic disease and residual inflammatory risk, HSCRP greater than 2.0, despite statin therapy. And these patients were randomized to an interleukin-1 beta inhibitor, canakinumab, which lowered cardiovascular event rates by 15%. It lowered CRP by about 35%. It lowered interleukin-6 by 40%. And again, this led to reduction in high sensitivity CRP. But the take-home message here from the CANTOS trial was that without affecting LDL, so you weren't treating cholesterol, you had a 15% reduction in cardiovascular events by just manipulating inflammation. That's a similar event reduction than was seen with the Fourier trial, the Odyssey trial, with the addition of PCSK9 inhibitors. So really, for the first time, treatment of an inflammatory risk translated into reduction in cardiovascular events.
Yeah, I mean, I think that's so crucial what Cantos taught us, and that article you mentioned by Paul Ridker showing that inflammation, residual inflammation, was probably more important than LDL cholesterol in predicting future cardiovascular events, was published in the Lancet in April of last year, 2023. If people are interested in looking that up, and I think Paul Ridker has been on the forefront of inflammation for a couple of decades. I mean, it was he who with the Jupiter trial showed us that if you pick people who have not just a high LDL but a high CRP, the use of high intensity statin reduced cardiovascular events more than you would have expected if you just chosen that primary prevention population based on their LDL cholesterol alone. So I sort of hate to have to acknowledge that while many of us think the lower the better and the longer the better in ApoB containing lipoproteins, sometimes if we don't consider background inflammation, we probably aren't giving our patients the best opportunity for reducing future events and residual risk. I think that's crucial. So, we have a anti-inflammatory agent that some of us may have used for treating acute gouty flares, called colchicine. Use it to reduce inflammation. Some cardiologists have probably used colchicine for another acute inflammatory situations, such as pericarditis or post-pericardiotomy syndrome. And those are short-term uses of colchicine at 0.6 to 1.2 milligrams a day in patients. But we now have some data that colchicine, which seems to affect the NLRP3 inflammasome and tend to reduce IL-6 and hence CRP, might be beneficial in reducing overall cardiovascular disease events in high-risk patients. So I know there are a couple of trials you'd like to try to explain about colchicine in that setting to our listeners.
Yeah, I mean, even before we get to the trials, one other area of inflammation we can certainly talk about later is those patients with elevated lipoprotein A, which is associated with an inflammatory state as well. But
Oh,
I think it's
absolutely.
important.
Oh,
Yeah.
yeah, absolutely.
And again, this gets into this whole discussion of residual risk. Remember, statins are that good, but what's better?
Right.
Or what can we add to the recipe to, make it more effective? But I think, just even understanding the mechanism of action of colchicine becomes important for us understanding how to use it in our patients. So we know that colchicine binds to tubulin, which inhibits this tubulin polymerization, disrupting the cellular cytoskeleton mitosis, and ultimately it affects the neutrophils, the activation of the neutrophils, the adhesion of the neutrophils, and its attraction to the inflammatory, the area of injury of the endothelium. So with that, you get inhibition of the release of the matrix metalloproteinases, the neutrophil elastase. Ultimately, you decrease the assembly of the inflammasome, and by decreasing inflammasome assembly, ultimately you're decreasing interleukin 1 beta, which then can produce interleukin 6, and down the road, high sensitivity CRP. There's also evidence that the colchicine may suppress smooth muscle cell proliferation and the fibrosis and the myofibroblasts that are also in the area. So this whole idea of affecting the inflammation of the endothelium becomes an important process for us to understand how this may ultimately translate into reduction of cardiovascular events. And with that being said, you have colchicine is something that you alluded to. We've used for many years at dosages up to 1.6, 1.8 milligrams per day. So here you have a dose of colchicine of 0.5 milligrams per day that was initially used in a trial called the LODOCO trial, which involved 532 patients with atherosclerosis. So these are patients with stable coronary disease who were already on statin therapy and antiplatelet therapy. They had a mean follow about 3 years, and they were treated with the low-dose colchicine, 0.5 milligrams daily, and they were found to have a lower rate of acute coronary ischemia, ischemic stroke, out of hospital cardiac arrest, and this kind of set up the thought process for a larger study looking at the benefit of colchicine in group. That led us to the LODOCO 2 trial, which again took patients with chronic coronary artery disease, placed them on LODOCO or colchicine 0.5 milligrams daily, and they looked for the benefit. The trial went up to 29 months, and they showed a reduction of cardiovascular death, myocardial infarction, ischemic stroke, ischemia-driven coronary revascularization by 31%. So the effect was really driven by reduction in myocardial infarction and ischemia-driven revascularization. Uh, the all-cause mortality in the LODOCO 2 trial was also neutral. But here again, you had an inflammatory therapy reducing cardiovascular events 31%. Again, compare this to the added benefit you got from Odyssey and Fourier PCSK9 inhibition, which was about 15%. So now you had
Yeah,
a trial in a chronic stable angina, chronic stable coronary disease, reducing events 31%.
yeah, that's awesome. And I do want to question that they didn't require the patients to have an elevated CRP to get into either one of these trials, correct?
Correct. No, what's interesting with all the colchicine trials, they didn't measure HSCRP throughout the trials. So there was one small group in LODOCO 2 that the numbers was too really small to draw a conclusion, but CRP was not a measurement needed to get into the trial. You were in the trial if you had coronary artery disease, stable
Yeah.
coronary artery disease.
And there's another trial called COLCOT. that was also an outcomes trial. Patients in that were post-MI rather than stable chronic coronary heart disease. You tell us anything about that?
Right. So the COCOT trial and was looking at patients with post-MI. So they were randomized. And here again, you're talking about 4,700 patients that were randomized within 30 days of acute myocardial infarction. And you had up to 14 days to start them on colchicine, again, 0.5 milligrams. The median follow-up was about 23 months, almost 2 years. And there was a 23% lower incidence of the primary endpoint here of reducing incidence of myocardial infarction, stroke. But the benefit of low-dose colchicine was most significant in reducing incidence of stroke and angina requiring revascularization. Uh, the drug was well tolerated. There was minimal increased adverse events, and there was a small increase in pneumonia, but there was no real difference between the colchicine and the placebo in terms of the gastrointestinal effects. So now you had a study of patients post-MI receiving benefit from the use of colchicine here.
Yeah, that's great. And, getting back to your explanation of the how colchicine probably works on the on inflammation and some of the basics of the initiation as well as the progression of atherosclerosis, not just trapping ApoB containing lipoproteins in the arterial wall, but also smooth muscle cell proliferation and so forth. I think there was also an optical coherence tomography study, an OCT trial done with colchicine, where they did show that you get an increase in the fibrous plaque and a decrease in the progression of atherosclerosis. Is that correct?
Yeah, it's kind of very interesting in terms of their findings because they also showed a decrease in the lipid arc. So on this OCT, you're looking at the extent of lipids there. So there was a reduction in the lipid arc. There was more fibrosis there, so that stabilized the plaque. And I think, and there was another study also showing reduction in plaque burden. So as you correctly point out, we're not only reducing inflammation, but we're changing the morphology of the biology of the plaques we're seeing and leading to more plaque stabilization. I think that's a great point.
Yeah. I think it's always important to understand exactly what we're doing with reducing inflammation. Yeah, the events go down, but why? Is it just antiplatelet effects or some other thrombosis effect? What is it? And it probably is a direct effect on the plaque composition, which probably makes things more stable. But I think that
Right.
The key issues here are we have an FDA approved drug now, and I want you to tell us exactly what is the FDA's indication for the use of LODOCO at 0.5 milligrams a day.
Okay, great. I just want to go back to one thing on
Oh,
our no, just that's fine. On our COCOT trial, which again, this was a post-MI trial, 0.5 milligrams of colchicine given within 30 days of myocardial infarction. The primary endpoint in that study was a composite of death from cardiovascular cause, resuscitated cardiac arrest, myocardial infarction, stroke, or urgent hospitalization for angina leading to coronary revascularization. And as I said, they were followed out almost up to 2 years, and we had a significant reduction in cardiovascular events here.
yeah,
So the point is, even as you refer to changing plaque morphology, changing plaque burden, part of the mechanism of action is that it may simply reduce inflammation, but more importantly, it may also reduce the effects of smooth muscle cell proliferation and fibrosis, as we said. So having less inflammation and a more stable plaque clearly would reduce cardiovascular events. So taking all this into account, the current indication for LODOCO, and again, I highlight this, we're talking about colchicine 0.5 milligrams daily, is to reduce the risk of myocardial infarction, stroke, coronary revascularization, cardiovascular death in adults with established atherosclerosis or with multiple risk factors for cardiovascular disease. And again, I just want to highlight the 0.5 milligram dose because here in the United States, we have 0.6 milligrams available, plus now the LODOCO on the market.
Yeah, that's an interesting point because the generic 0.5 milligrams, 0.6 milligrams of colchicine has been around for decades for us to use in those conditions of inflammatory things like gout before. So it does raise the question about, should you use 0.5 or 0.6? Well, in my mind, it really gets down to tolerability. So why don't you, before we decide on dosing, what are the issues or side effects that may come from taking colchicine?
So the biggest side effects are, gastrointestinal side effects could be, diarrhea, could be some nausea, vomiting, maybe up to 10 to 15% of patients. Interesting with the LODOCO 2 trial, they did a 30-day run-in to see who could tolerate the colchicine 0.5 milligrams. And then if the group tolerated it, then they divided them up into the treatment and placebo group. So really you're talking about GI side effects. And what they also found in studies was that if the patients were able to get through the initial, for the group that was sensitive to it, to get through the initial GI upset, they were able to tolerate the medication throughout the trials. So really, we're just talking about gastrointestinal side effects being the major side effects of concern.
Yeah. So again, do you think in your mind that there's a difference in 0.5 and 0.6 milligrams initiation? Getting back to your point about what's those two available doses, as far as patient tolerability, should you use 0.5?
I think,
easier?
no, I don't think it's easier. I think also at 0.5, you have a low dose colchicine therapy. At 0.6, again, think of where we were using it. We're using in, acute gout. We can use it for prophylaxis of gout. They showed some safety with familial Mediterranean fever, people on it chronically.
Right.
Post-pericardotomy syndrome, some cardiology with, familiar with it, but the LODOCO dosage of 0.5 was, safe and well tolerated. And just as importantly, it had no interaction with any of the statins, the antiplatelet agents, antihypertensive agents that we do use. Now, the caveat also is that you'd like to use the LODOCO, low-dose colchicine, in patients with normal renal function. The minute the patients have renal dysfunction, moderate to severe, you're going to have, various steady states of colchicine going up and down, and you have a much wider safety margin in patients on the 0.5 milligram dose. If patients have renal impairment, that 0.5 safety margin is going to be shorter, but if you on the 0.6 milligram dose, you're going to have, many more patients going into more toxic level. So I think the 0.5 milligram dose is, safe, well tolerated. Again, guideline therapy would be, use the 0.5 milligram doses was used in these studies.
Yeah. So, do you have a cut point, or is there a cut point in the indications from the FDA as to what EGFR is safe to use 0.5 milligram colchicine?
Well, the package insert will say, since colchicine is excreted by the kidney, avoided in patients with, moderate to severe, kidney disease. Within looking at the LODOCO trials, patients that had normal creatinine clearance of 60 cc's per minute or greater, had no issues. So in normal renal function, you were doing well. There was also some information that the patients that had GFR of less than 60 cc's per minute didn't do as well in terms of event reduction. So I would say until more data is available to us, we should really look to use this dosage of colchicine 0.5 milligrams in patients with normal renal function of 60 cc's per minute or greater.
Yeah, yeah, I was feeling that was the case as well, which sort of reduces to some degree our high risk patient populations that tend to have some underlying CKD, along with, for instance, diabetes and or hypertension that have affected their kidney function. They're high risk patients, but using colchicine might be a little bit more challenging for them with EGFRs from 45 to 60. So I think that's a good caution to have in that regard. So, one of the things that you have to get down to in the big picture, we're talking about residual risk here as far as inflammation is concerned, but there are other residual risks. LP little a, for instance, is one that we're going to be hopefully figuring out in the not too distant future as an important target for a residual lipid risk. But, we have other studies that have of drugs that have reduced cardiovascular disease events in these same type of patients that we have in the LODOCO trial, such as GLP-1 receptor agonists and SGLT2 inhibitors. And, a lot of times our patients have diabetes, and we know that they reduce cardiovascular disease events. So if we want, and obesity, where GLP-1 receptor agonists have also reduced cardiovascular disease events in those with obesity and diabetes. So if we were to choose those drugs to, quote, attack our residual risk, they reduce inflammation, SGLT2s and GLP-1s. Do you still consider colchicine, if you're going to use those drugs, another choice to add on those circumstances?
Well, I think that's a great point. I see colchicine as a very cheap option, in terms of compared to the expense of GLP-1 agonists, between cost of drugging, lifetime therapy, and also the patients have difficulty getting prior authorization. Some insurance won't cover it, but at a 0.5 milligram dose of low dose colchicine for the right patient, I think you have an affordable intervention that's been shown to reduce cardiovascular events 31% in patients with chronic coronary disease and 23% post-MI. So until we have something else, I think in the right patient, oral low-dose colchicine 0.5 would be cost effective and certainly efficacious in reducing cardiovascular events.
Yeah, I tend to agree. Those other drugs tend to be not only challenging in their own sense for patient tolerability and use, but they are much more expensive. So that does give us pause for thought on how we use additional drugs in our high risk patients. I want to get back to the downstream marker of inflammation, hsCRP. It's not a mediator of inflammation. It's just a biomarker of increased presence of interleukins and things that have stimulated the liver. But do you think we need to measure hsCRP routinely in our patients, and is it necessary to have a high CRP to prescribe colchicine?
That's actually a great question. I just want to throw a wrench in one of the things you mentioned before when we talk about the benefit of GLP agonist intervention and reducing inflammation. The question will be down the road, if you have that group of patients on colchicine or medication like colchicine, is that going to be as beneficial from an inflammation standpoint and reducing cardiovascular events? Clearly, GLP also has, weight benefit associated with
Right.
changes the whole milieu. So just like we have patients on statins, just like we have patients on fish oil, just like we have patients on, second degree lipid lowering of ezetimibe, the use of colchicine may be quite helpful. So in terms of, CRP, based on these trials, you didn't need to look at CRP to have benefit if you had coronary artery disease or if you were post-MI. I'll talk a little bit about some of the future trials down the road. I think, again, in my personal practice, I do look at HSCRP as identifying a group of patients that do represent higher risk. Now, we've all had patients, receive coronary stents. We've had patients have coronary artery bypass, and they go on to clinical events, and we see that their HSCRP is elevated. We also see a bunch of those patients have a high LPA, which contributes to that as well. So I do use it. And again, we can go back to the study that you referenced that Paul Richter did with the meta-analysis from the 3 trials with fish
Yes.
oil. And he's really looking at baseline HSCRP and on statin therapy. And he showed that the group at highest risk was the LDL greater than 70, HSCRP greater than 2. But the second highest risk group was LDL less than 70 and HSCRP greater than 2. HSCRP is certainly affordable now. I remember when it first came out, United Healthcare and some of the other insurance companies wouldn't pay for it. It was experimental. So it's an opportunity for us to use a cheap test now to gauge someone's risk. So I do use it, and I think it's an important tool, as I said, to look at ongoing risk.
Right. I agree with that. You know, we've talked about positive trials that showed benefit of targeting inflammation. I do want to mention that there was a negative trial that looked at methotrexate called a cardiovascular inflammation reduction trial, CIRT. It was published in the New England Journal, I think, in 2019. They looked at almost 4,800 patients for 2.5 years with established cardiovascular disease and diabetes. And methotrexate didn't work. There was no benefit on major acute coronary events. And actually, CRP did not go down, neither did IL-6. So methotrexate we consider to be somewhat of an anti-inflammatory, but it didn't lower CRP or IL-6 and had no benefit in these high-risk patients. So it does tend to show that colchicine has a unique place as an oral therapy to reduce events targeting inflammation. And I believe
Yeah.
So do you think there's, I mean, canakinumab was an IV infusion. It never, even though it reduced cardiovascular events post-MI, it never got pursued for clinical approval, probably because of cost and difficulty in administration and patient compliance and all that as a IV administration. But I believe there's a future drug that's being looked at on cardiovascular disease events. Do you know that one? I think it's ziltivekimab, a monoclonal antibody.
Yeah. I'll let you get back to that in 1 second. I just want to make a point for us here. Methotrexate may not have been the right tool for the job. If anyone's a little handy and you're going to take a hammer to a wrench, it won't work. So I believe methotrexate really targeted interleukin-6, and what colchicine did was target, one interleukin-1 beta, and canakinumab also targeted interleukin-1 beta, which again, everything downstream was affected by it. So it may have been the wrong target with methotrexate, with just going at interleukin-6 without affecting the inflammasome, which occurs above it. So, just one point to make with that. As far as the canakinumab, there was increased infections. That was one thing, and then they found that it actually reduced lung cancer. So the drug was kind of stolen away to go into the oncology world. But again, with the purpose in our discussion really was it highlighted the importance of reduction of inflammation, reducing cardiovascular events. So I think that reinforced the inflammatory story of cardiovascular events
Yeah.
for us. But if you want to talk to us a little bit about the other monoclonal antibody you're talking about? I know they're looking at that in patients with chronic kidney disease.
Yes, yes, they are actually. It's interesting you mentioned about the target of IL-6, not necessarily the NLRP3 inflammasome, which is farther upstream. Ziltivekimab is in trials right now in a cardiovascular outcomes trial, and it is a monoclonal antibody to IL-6. So they are actually targeting IL-6 in patients with established heart disease. They have to have an elevated CRP to get in to the trial, and they have to have background chronic kidney disease. And the outcomes trial is called Zeus, and it's ongoing. So who knows where that's going to take us, but it may help us understand a little bit more about this whole residual inflammatory field as it relates to cardiovascular disease events and what we can do as clinicians. So, I mean, I think if we were to sort of wrap things up here with, we're all, clinicians trying to reduce vascular events in our patients, and we try to use standard of care the best we can, which includes lowering LDL and ApoB containing lipoproteins as much as possible, treating hypertension, controlling diabetes, positive lifestyle changes. We feel that the evidence from LODOCO 2 and the FDA indication from colchicine that along with all the stack of medications we may be giving our patients to reduce cardiovascular disease events, maybe colchicine should be one that we should strongly consider. Do you agree with that?
Yeah, and I want to point out that this is really just the beginning of the benefit of colchicine 0.5 milligrams of LODOCO. There's ongoing study now called the Clear Synergy trial, which is colchicine spironolactone in patients with myocardial infarction, and stent registry, which is looking to randomize 7,000 patients with myocardial infarction treated with PCI, either colchicine or placebo. And they're going to get more data looking at the, question of inflammation in that group. There's another study, the colchicine cardiovascular outcome in patients with acute coronary syndrome, taking colchicine 0.5 milligrams again in 3,000 patients with recent acute coronary syndrome and HSCRP of greater than 2. And then there's another trial called the Mintz trial looking at colchicine for prevention of vascular inflammation and non-cardioembolic stroke. And this is 2,600 patients with an acute stroke or TIA. So again, where we talked about the LODOCO and the COLCOT trial and reduction in stroke, there may be a whole other world of looking at the benefit of colchicine in cerebral vascular disease, which was again one of the primary endpoints, and then looking at that HSCRP question. So I think you make a good point. Sure, that our patients are on a variety of medications, but as we look for personalized medicine and targeted medicine, there'll be a group that has ongoing inflammation. And again, these studies didn't use CRP. There'll be a group of patients that have ongoing clinical events post PCI or post CABG or have a TIA after they have cardiovascular disease. So it really comes down as us as clinicians identifying which group of patients would benefit from a medication like LODOCO. And just to highlight again, it's currently indicated to reduce the risk of myocardial infarction, stroke, coronary revascularization, and cardiovascular death in patients with established coronary artery disease or with multiple risk factors of cardiovascular disease. That's a big, wide indication. It doesn't depend on HSCRP, and it may just say, hey, here's your, low-dose aspirin, and here's your low-dose colchicine. But as clinicians, we'll have to sort out who, would benefit the most, for this.
Yeah. Well, I'm looking forward to those other ongoing trials with colchicine to help us understand more about where it plays a role. But it certainly is a oral therapy that patients can tolerate most of the time, and it's going to be a chronic therapy. So we always have to remind them that this is something they would take for the long haul, and hopefully they will in order to get these benefits. Well, we've had a wonderful discussion guys. Is there anything else you want to wrap up with before we try to close out?
I just think it's something that clinicians should consider. Many times we're just do things rote. Okay, you're on statin therapy, check. You're on antiplatelet therapy, check. But the patients are more than a checklist. We need to look at them as a whole and understand their cardiovascular risk, and that would include risk enhancing features, as you highlighted so nicely at the beginning, other disease states, other biomarkers that become important, HSCRP and LPA, and it becomes important for us to really personalize the way we treat patients and looking at inflammation, as I said at the very beginning, to balance out the 50% reduction we get from statins. So having a 25 to 31% reduction with the addition of colchicine to our standard therapy is pretty good. If I like to tell patients who push back, if I sent you to Vegas and you had a 25, 30% winning, would you take the shot? But I think as
Yeah.
clinicians, we got to build on the 50% benefit that we've seen with statins and the 15% benefit more with, maybe the addition of PCSK9 and other lipid lowering things, and, really understand that there is residual risk. And that's the term that many primary care physicians are not familiar with, many cardiologists are not familiar with. Understand that inflammation represents a residual risk to our patients, and now we're developing tools to reduce that residual risk. And HSCRP may be one of the tools that we use to identify residual risk. But in this particular case, as I said, there's a wide mandate to using LODOCO in your patients with cardiovascular disease or at risk for cardiovascular disease.
Yeah, I couldn't have said it better, Guy. That is fantastic. So I want to thank you, Guy, for your wonderful instructions and insights today. And I also want to thank all of you for listening to this first episode of the NLA's new podcast series, Industry Innovations. Hope to see you again soon.